last lecture we discussed regarding what are the road to ECG time, road to W time, which patient which need to go for primary PCI, and which patient need to undergo on the basis of some criteria, grace score, TB score, and ultimately aim is to recover the myocardium and salvage myocardium as early as possible. So onset of symptom, from onset of symptom to the presenting, the time duration which ultimately matter. So I briefly just want to go through the last discussion. Remaining 10 to 12 slides, the last slide we will discuss on today's lecture. So these are the pre-hospital assessment, initial ECG will decide. And this is the in-hospital. When we are in doubts, then go with troponin and ECG, it will tell serial monitoring. And based on the clinical aspect of patients, whether it is intermediate risk, low risk or high risk. And these are the risk stratification, TB score and grace score. These are the patient presenting with cardiac arrest which need to address. Like patient is awake, patient is comatose, but if prognosis is not favorable, then we cannot go to the primary PCI. So standard medical therapy, as we all know, that oxygen therapy, analgesics, nitrate, antiplatelet, and oral P2Y12 inhibitor, ticagrelor, prasugrel is preferred over clopidogrel. And these are the
hospital morphine available. Morphine available. Yes.
Aspirin અત્યારે પણ નથી પ્રિફર કરતા એક્યુટ સેટિંગ ની આ નવી ગાઈડલાઈન ની અંદર ક્લોપિડોગ્રેલ પ્રિફર ઓવર ક્લોપિડોગ્રેલ કરતા પ્રાઝોગ્રેલ અને ટિકાગ્રેલ પ્રિફર કરે.
they are more potent because
પણ એસ્પિરિન નો હવે અંદર રોલ જ નથી એક્યુટ માં પણ
aspirin plus P2Y12
એસ્પિરિન પ્લસ
dual antiplatelet.
But aspirin patient dose માં આપવાની.
When patient undergo PCI, then for prevention of stent thrombosis, we use clopidogrel. So these are the antiplatelet intravenous GP2B3 inhibitor, Ringrelor, parenteral anticoagulant, and lipid management, as you all know, target LDL should be less than 70 or less than 55. Beta blocker, anti-angiotensin system, reperfusion strategy, as you all discussed, like patient presented with shock, then directly go with the primary angiography, angioplasty, or CABG surgery based on the patient's severity. If onset of time less than 12 hours, then if facility is available, then directly perform this class 1 indication. If 12 to 24 hours, it is still reasonable to go with the better outcome of patient, to go with the primary PCI, it is class 2A indication. Or if more than 24 hours, it depends whether it is patient PCI should not be performing due to lack of benefit because it's already late more than 24 hours and there is class 3 indication. And in some time, if ongoing arrhythmia, LV dysfunction and ongoing symptom, then we can take a course. So last slide we all discussed. So this is the slide regarding coronary angiography and PCI after fibrinolysis. Many of time patient peripheral they thrombolize with whichever available. So then after fibrinolysis, the patients having persistent symptom, fail reperfusion like ongoing chest pain, ST segment resolution less than 15, anterior lead less than 70% in inferior lead, unstable hemodynamic arrhythmia, then transfer to PCI capable center with class 1 indication, which called rescue PCI. If patient after thrombolysis, usually they say class 1 to 24 hours after thrombolysis, sometimes it will causes the reocclusion or like failed thrombolysis or with that. So based on that, routine invasive versus selective invasive, which patient we need to selectively we can approach, or which patient need to routinely we can approach. High or intermediate risk, this is for non-ST elevation, this is for ST elevation. So in non-ST SCS, high or intermediate risk based on grace score or TB score. So routine invasive strategy is class 1, or low risk we need positive, go with the angiography. If it is negative, start with the medical therapy. So what are the rationale or timing for a routine invasive or selective invasive? Is that if patient having very high risk, go with the immediate invasive strategy class 1. High risk, then class 1, but it is coronary angiography will take about less than 24 hours. Intermediate risk, less than 72 hours or before hospital discharge, or lower risk. Last slide we discussed that part. So catheterization for consideration in ACS stent, radial route is preferred over femoral route. The advantage is that it will take much time, it will create less bleeding, patient compliant, convenience. Radial approach is preferred in femoral approach to reduce bleeding, vascular complications, and mortality. And they said that intravascular imaging during the primary PCA, some trial like Renovate complex PCA trial, which suggests that it is easy and guide to the procedure and it will benefit to the outcome. Among patients with ST elevation undergoing primary PCA, manual aspiration thrombectomy should not be performed routinely. In many of centers, they perform thrombossuction, angiography showing the high risk of thrombus burden. So at the time of guidelines say that suction is not as much useful. Many of times thrombus will dislodge from the vessel or in brain or any of whatever. So these are the contraindications for routine invasive approach in ACS. Many of time patient having high bleeding risk, low platelet count, altered creatinine, baseline creators, limited life expectancy 1 to 2 years, having some dementia or having non-previous coronary anatomy patient results. So we cannot very go with the imaging. So management of non-infarct related artery. The patient having diabetes presented with ACS, culprit arteries, LAD, so rest of the vessel is also having disease, LCX and RCA. So guidelines say that at the time of primary PCA, you can do PCA to the other vessel as well. There is a class 1 indication for that. Many of time they advise to discharge, can follow, we will do a stage plastic. ST elevation MI with multivessel coronary artery disease. Patient with cardiogenic shock, that only touch culprit vessel. Do not take too much time on another vessel. PCI, routine PCI of non-infarct related artery at the time of PCI should not be performed because of the high risk of death or renal failure. There is a class 3 indication. If patient is stable, he will tolerate well procedure. If hemodynamically stable, so do first PCI to the complete vessel. After successful PCI of the infarct related artery, elective CFD significantly stenosis vessel, non-infarct artery involving the large territory of LAD vessel or left main is reasonable. Class 2, if complexity is there, left main vessel is there, then go with the CFD. If low complexity of multivascular disease apart from main vessel, after successful PCI of infarct related artery, PCI of non-infarct related artery is recommended to reduce rate of death or MI. Multivessel PCI of significantly stenosis non-infarct related artery at the time of primary PCI may be preferred over a stage approach. In last 2021 guideline, they used to say class 2 indication, and now it is a class 1 indication. At the time of presentation, ACS, do all the procedure at the, if patient tolerate procedure well and more dynamically stable. In what about non-ST elevation ACS? If patient having multivessel coronary artery is the same as like ST elevation MI, patient in cardiogenic shock. So routine PCI of non-infarct related artery should not be performed. If patient hemodynamically stable, so mode of revascularization, either CABG or multivessel PCI, should be performed based on complexity of vessel, disease, toxicity, type of lesion, whether type A, type B, type C, or patient's comorbidity. Multivessel PCI, stenosis of non-infarct related artery recommended to reduce risk of death. Again, it is class 1 indication. At the time of physiological assessment, FFR, PFR, you can do. It is a class 2 indication. And CABG, patient with complex angioedema, then CABG. These are the stories of coronary revascularization, of complexity of significant left main, coronary stenosis, multivessel coronary artery disease, diffuse disease, diabetic vessel, multivessel disease with severely impaired left ventricular function. So in cardiogenic shock, patient present in ACS condition, revascularization class of recommendation one is patient unstable, emergency revascularization only to pulpit vessel, either with PCI or CMPT. It is indication. It is for survival of patient. And class 3, non-infarct related artery do not touch at the time of primary PCI. Mechanical circulatory support when patient in cardiogenic shock, they said that IBP and ECMO is not as much as beneficial. Class 2 indication is we can use insertion of intravascular flow from microaxial. Class 2 is mechanical complication after ACS, chorda rupture, any of patient having severe LV dysfunction, which shock. It is reasonable to stabilize patient, it is bridged to surgery. And class 3 in patient with cardiogenic shock with acute MI, routine use of IBP or ECMO is not recommended due to lack of survivability. What are the complications? There are two complications, mechanical or electromechanical complication. So, patient with mechanical complication, these are the like papillary muscle rupture, mountain rupture, ventricular septal rupture or free bone rupture. Patient is deteriorating, unstable hemodynamically.
What is that contained?
So it will outcoach the LV like any resistance segment. So in that case, patient with mechanical complication of ACS should be managed in facility with a backup of cervical or CVS backup. Class 2A is patient with mechanical complication ACS short term mechanical circulatory support device is reasonable for stabilization, bridge to surgery until the facility is available. What are the electrical complication and prevention of? Many of time our center only IBP and is available, ECMO in other option, but mechanical circulatory support is too much costly and will again the time for patient to decide. Electrical complication and prevention of sudden cardiac death after ACS, whether is tachyarrhythmia or bradyarrhythmia. In ventricular arrhythmia, post MI, starvity or any of such incidents will take a time for the automatic ICD, AICD to do. Like it is recommended to select a patient with an LVEF like less than 40 or 35, at least 40 days post MI and at least 90 days post PCI. Myocardium should be recovered within that time period of time. So it will, myocardium will recover, then no need to PCI, but in the patient high risk, advice to AICD, class 1 recommendation. Ventricular arrhythmia in patient with ACS, ICD implantation is reasonable in patient with clinically relevant ventricular tachycardia more than 48 hours within 40 days post MI. Class 2A in the ventricular arrhythmia in patient post MI, temporary wearable cardiovascular defibrillator is uncertain in patient with LVF less than 35% to improve survival. These are for those high-risk patients who survive after MI. And bradyarrhythmia in patient presenting with acute MI having large territory, supradominant RCA with evidence of second-degree morbits, type 2 flow, high-grade AV flow, bundle branch, bundle branch flow, third-degree AV flow. Permanent tracing is indication in class 1 indication. So first do the PCA of that vessel and then later on. Clinical criteria for diagnosis of pericarditis. Many of patients having undergone PCI, there is a sort of inflammation which causes to the elevation of ECG changes after acute phase or subacute phase, and then having chest pain, then echo suggestive of some collection around the pericardium. So Clinically, we can say that more than 1/3 of the following criteria: patient having respiratory frictional rub or pericardial rub, ECG showing PR segment depression with elevation, and new or growing pericardial effusion. And these are the, we can add additional therapy from antiplatelet or statin. High dose aspirin 1 gram 8 hourly or colchicine as per weight of patient. These are the in-hospital issue management of SCS. Initially 24 to 48 hour in-hospital ICU, cardiac ICU with monitoring, oxygen monitoring, and cardiac intensive care monitoring. Patient having persistent angina, post-procedure, post-plasty. Patient having AVR, arrhythmia, uncontrolled, hemodynamically unstable, or patient persistent in cardiogenic shock with LV dysfunction and AKI. There is a class 1 indication of cardiac ICU. Daily monitoring, again, it is recommended to reduce cardiovascular event. Echocardiography, last lecture sir told me that I sent sir to all the slides. Nowhere they mention echo. Only they told that the echocardiography you can use an initial to define whether it is how much LV dysfunction and on discharge process. Neither they will take a call based on echocardiography. You cannot thrombolyze.
on discharge તમે કહો છો તો પહેલા કંઈ કરેલું હોય તો તમે કમ્પેર કરી શકો.
Initial assessment.
ઇનિશિયલ એસેસમેન્ટ હોય તો જ તમે સેકન્ડરી કમ્પેર કરી શકો.
What I said is the clinical scenario. Say the patient comes. Say maybe your troponin initial 1 hour may not be that significant because you have to repeat after 3 hours. Patient is doing ongoing case pain. Your ECG doesn't show changes, but patient is in agony. Patient is in perspiration, severe chest pain, exhaustion, and clinically you suspect that this patient is an infarct. Your troponin T1 करो, એટલો ના જોવા. ECG changes, ECG are not specific or doesn't show any changes. What do you do? The fourth thing you do is the echocardiogram. If echo suggests that the patient is in regional wall motion abnormality, that suggests this patient is developing infarct.
So they said the clinical decision making pathway, so we have to suspect dissection, embolism.
I said on a recent, even I have diagnosed in a 35-year-old young patient whose ECG was absolutely normal, troponin was normal, and I said me go for angiography and triple vessel disease. And that patient has to undergo type of CMD. Point is, if the clinical history suggests that you cannot wait for another 4 hours for troponin to become positive, or maybe after 1 hour, you cannot wait for 1 hour ECG to become positive. What is it? Immediate at hand, what do you have? Echocardiogram.
There has to be a place for echocardiogram.
Echocardiogram is everyone available.
Surprisingly,
Even though it is not recommended, but see, in practical sense, what do you have at your hand? Immediately you go for echocardiogram.
Indirect evidence. ACS guideline mainly say patient have transmural infarct, ST elevation, then you need to be a panic. Otherwise, stabilize them, evaluate them, and then we consider blood transfusion in patient having anemia less than 8 HB or less than 10 HB, stabilize the hemoglobin first with either transfusion or patient education, lifestyle modification, and medication and follow-up care. Education regarding and awareness regarding the disease, lifestyle changes, some medication, regular follow-up is need to address on research. Post-research follow-up and system of care coordination, communication, patient-centric or shared decision making. Cardiac rehab is as much as important. Exercise, nutrition, weight, BP, lipid, sugar, reversible factor, or physical activity, psychological management. What about DAPT strategy? First 12-month post-discharge. Usually here we prescribe aspirin with oral P2Y1 inhibitor, Vasudeva or Ticazole. And after 1 year we switch to single antiplatelet, clopidogrel. It will cause a less bleeding. So the patient with SCS who are not in high bleeding risk, dual antiplatelet with aspirin with oral P2Y12 inhibitor should be administered at least 1 year to the reduce major adverse cardiovascular event class 1 indication. The patient with ACS who have tolerated dual antiplatelet therapy with ticagrelor, transition to ticagrelor monotherapy after 1 month post PCA useful to reduce bleeding risk. Many of time patient in this category default strategy bleeding reduction strategy and high bleeding risk. So many of trial short DAPT, ultra short DAPT, they said that 1 month dual antiplatelet followed by single antiplatelet. But usually they said that in default strategy dual antiplatelet more than 12 months with aspirin with P2Y12 inhibitor, ticagrelor, prasugrel, P4 over post PCI to reduce the stent thrombosis. Bleeding reduction strategy, patient having like moderate bleeding risk, then go with the 1 week of dual antiplatelet therapy, discontinues aspirin, and then switch over to single antiplatelet therapy. Ticagrelor monotherapy. Triple therapy, add NOAC with dual antiplatelet therapy, discontinues 1 antiplatelet aspirin, and then oral anticoagulant with single antiplatelet therapy monotherapy. Dual antiplatelet for the 1 month, Rex or ticagrelor with aspirin, and then de-escalated potential P2Y12 inhibitor and aspirin plus clopidogrel. Class 2B to reduce the bleeding prevention. In patient on those category with high bleeding risk, dual antiplatelet therapy, aspirin plus P2Y12 inhibitor for 1 month followed by single antiplatelet therapy. What about patient having already AF and already on anticoagulant or like any history of operative valve? Then in that case, you use dual antiplatelet with direct oral anticoagulant if no contraindication post PCI. After 4 weeks, de-escalate 1 antiplatelet, continue with direct oral anticoagulant with P2Y12 inhibitor. Again, it will be based on the age, risk factor, comorbidity, and how much the bleeding risk. With the bleeding risk group, we can reassess. Again, assessment of lipid level on the time of discharge. Previously we told that LDL should be at least controlled below the 7%. Lipid lowering therapy initiation. If young patient we started high dose statin and follow 4 to 8 weeks, reassess LDL or fasting level class 1 indication. If LDL control, then continue current therapy. If it is high, then we can use PCSK9 or ezetimibe or opioid. Immunization until unless
Number target 55 to 70 LDL
55 is the
at the end of 4 weeks. Just 55.
acute coronary syndrome.
So
The
the
chronic coronary syndrome we can accept.
પાછલી સાઈડમાં જે ટાર્ગેટ અચીવ થઈ જાય પછી જે કન્ટિન્યુ સ્ટેટિન છે એમાં સ્ટેટિનનો ડોઝ રિડક્શન કરવાનો કે સેમ રાખવાનો? LDL at target or low, then continue current therapy. So rosuvastatin 20 ચાલતી હોય. So I have seen many cardiologists make it alternate day or reduces the dose. Is it proper?
No, sir.
You have to continue 20.
When the event has been occurred, so based on that, at least it should be aggressive. And immunization, annual influenza vaccine to reduce the risk of death of major cardiovascular. These are the future direction. So I just covered the rest 10 slide which were last.
Sorry, I came late, but is there any indication to continue DAPT more than 12 months?
It will based on the like bleeding risk, how much patient can tolerate.
Patient is absolutely low bleeding risk. Then DAPT should be continued beyond 12 months.
Thermal actually only
Clinical
monotherapy.
practice, the
Clinical practice almost all are continuing,
All are.
specifically those who are under care of cardiology.
But guidelines say 12 months is enough.
There is no role more than 12 months, right? DAPT.
Yes. Previously it was bare metal stent, so nowadays the diluting or
What are we doing with them?
It's like indication in small vessel or like 70% of that branch, I mean 2.5 millimeter diameter.
So we drug it elutes, and because during balloon blast it will elute, otherwise you are not putting anything there. So you are not getting any long term or medium term advantage. Just while you are doing balloon blasting, that is when the drug is used. So which drug it is? Paclitaxel only?
So it will again need 3 months of antiplatelet, dual antiplatelet followed by 1 month of single antiplatelet.
So you, how you inject it, or it is there on the surface of
It is
balloon?
coated on that balloon.
Coated on the
We
balloon.
insert that balloon on that wire and then inflate. So the layer of drug will
But the contact area will be very less. How this will be achieved? Like, do you have any pictorial or video or something like that to make that understand? बताओ आमा નથી ત્યાં કોઈ તો લેતા આવતું
yesterday one patient we did balloon video.
drug eluting balloon you use.
Those patients were having ISR, so prevent the mental load. Right? That is one of the options.
So that patient was having ISR.
ISR, yes.
ક્યારથી વાપરો છો drug eluting balloon?
Since first we use before 1.5 years.
દોઢ વર્ષ
આપણું ફ્યુચર ડ્યુરેશનની અંદર ટ્રાન્ઝિશનિંગ ફ્રોમ એક્યુટ ટુ ક્રોનિક કોરોનરી સિન્ડ્રોમમાં ડીએસ્કેલેશન ઓફ એન્ટીપ્લેટલેટ થેરાપી હતી. પણ તમારી પ્રીવિયસ ટાઈમની અંદર ડિફોલ્ટ સ્ટ્રેટેજીની અંદર ઇટ હેઝ ટુ બી કન્ટિન્યુ ફોર મોર ધેન 12 months ડીએપી.
In future, this patient when become
એટલે ફ્યુચરમાં એમણે જે કહ્યું એ 12 months પછી એ કરતા.
આ patient ફ્યુચરમાં બનશે ક્યારે લેટર ઓર ક્રોનિક કોરોનરી સિન્ડ્રોમ સાથે પ્રેઝન્ટ થાય.
પોસ્ટ ડિસ્ચાર્જ તમારી એક સ્લાઇડ છે ને જુઓ. પોસ્ટ ડિસ્ચાર્જ આવે પોસ્ટ ડિસ્ચાર્જ. હા આમાં જો પહેલી આમાં ડીએપીટી ડિફોલ્ટ સ્ટ્રેટેજીમાં ડીએપીટી ફોર મોર ધેન 12 months ડીએસએફ ક્લાસ 1
At least 12 months. The low level duration is 12
મોર
months.
ધેન ઓર ઇક્વલ ટુ 12 months તો છે પછી બી
પછી continue, you can
So
continue.
again question comes કે આ જે ટેબલ છે એની નીચેનો ડિસ્ક્રિપ્શનમાં એક લાઈન એવી હશે કે more than 12 months ક્યારે આપો.
Ultimately, they say the clinical decision making in everywhere.
ક્લિનિશિયન તો આપણે બહુ એક્સલન્ટ છીએ જ બધા, એમાં એ તો કોઈ વાત જ નથી, રાઈટ? પણ what is the scientific indication of continuing DAPT beyond 12 months?
આમાં તો ડિફોલ્ટ સ્ટ્રેટેજી હતી મીન્સ મોટા ભાગમાં કન્ટિન્યુ રાખવાની unless there is a high bleeding risk by first.
Yes. Patient having like high risk of thrombogenicity. Or
See, you need to realize one thing. Your patient is one ASCVD risk factor is always going to be very high risk all of your life, right? So it's a high risk factor.
Yes, the patient is still.
બધામાં ચાલુ રાખવાની રેફરન્સ.
અત્યારે કેવું unless they you are falling in bleeding risk
માની લો patient ને સ્ટ્રોક થયેલું છે પહેલા carotid stenosis છે renal artery છે.
બાકીના બધા કેટલા છે, રાઈટ? તો એનું કંઈક હશે. આ તો તું માનો કે બોલે છે, માનો કે તો ચાલે ને ના?
Yes.
એમ તો હું બહુ બધું બનાવી દઉં. આ તો એ વાત થી હાર નહીં હોતી જબ તક આદમી જીતા हुआ रहता है. એટલે બ્લીડિંગ નથી ત્યાં લગી તમારે જીતે જ રાખવાનું. ઇટ ઇઝ વોટ ધીસ પોઈન્ટ ઇઝ.
એટલે આ bleeding તો એવો જ થયો કે અત્યારે જ્યાં સુધી તમને કઈ તકલીફ નથી.
But after 1 year, there is a less chances of like stent thrombosis or ISRs. We can de-escalate develop them.
That is a future direction.
મેં સ્ટેન થ્રોમ્બોસિસ ના મેક્સિમમ ચાન્સીસ 6 months ની નીચે જ છે.
Yes. 3 months to 6 months. So, clopidogrel can less frequently use. Okay. Resistance and chances.
ઇકોની વાત કરી તમે?
Yes, sir.
આ જો ડિસ્કસ થઈ ગયું છે આમાં તો લખે છે ડિસ્ચાર્જ વખતે તમારે ઇકો કરવું જોઈએ તો ઇકો કમ્પેર કઈ રીતે કરો તમે પહેલા કરેલું હોય તો
તો
જો આમાં આવી ગયું આ આખી સ્લાઇડ તમે જો ઇન હોસ્પિટલ ઇશ્યુઝ ઇન ધ મેનેજમેન્ટ ઓફ એસીસી એમાં આટલું લખેલું છે કે ઇન પેશન્ટ વિથ એક્ટિવ કોરોનરી એન્ડ એસેસમેન્ટ ઓફ એલવીએફ ઇઝ રિકમેન્ડ પ્રાયર ટુ હોસ્પિટલ ડિસ્ચાર્જ. હવે એ તમે કમ્પેર ક્યારે કરો પહેલા કર્યું હોય તો
Initial assessment tool my coding includes.
મેં તને સ્ક્રીનશોટ મોકલ્યો તેમાં ઇન્ડિકેશન સ્પેસિફિક લખેલા હતા.
I know that's another, but whenever they mention based on eco, you can.
But that is a catch point, right? Because there are so many decisions you are going to take on eco, right? હવે initial description માં શું કામ નથી કે they are constantly focusing on કે ભાઈ needle eco ચાલુ ગમે તે, right? Okay, but જેમ કે hemodynamic instability હોય ને તમે eco ના કરો, it's a negligence.
Okay.
You will agree, right?
You can without eco you can. Without at least it should.
આ કોઈ પોસિબલ જ નથી, અધરવાઇઝ તમે ચેક કરવાના છો, રાઈટ? અને એમાં અમુક જગ્યાએ તમે રપ્ચર પપ્ચર થયેલા હોય એટલે થ્રોમ્બોલાઇઝ કરી નાખો કદાચ, મજા પડી જાય ને. આમાં પેલું જિંદગી ઝંડવા ફેરવી કમંડવા એવી વાત થાય પછી.
એટલે ઇકોની ટેસ્ટ તો હોવું જોઈએ.
અને જે ઓલો સ્ક્રીનશોટ મોકલો તો એમાં that was in the early assessment only. યાદ છે એ બધું શું શું લખ્યું હતું એમાં?
Urgent echocardiography, the diagnosis in chest pain, initial medical treatment should begin immediately with patient suspecting ACS or mechanical complication. For diagnosis of mechanical complication, echo is necessary. Another point is, if we are suspecting the LV thrombus or less than 30% ejection fraction, large vessel involvement or any significant patient deterioration, then echocardiography is recommended initial modality of diagnosis. Although cardiac MRI is more sensitive in detection of this.
કાર્ડિયાક એમઆરઆઈ તો ઇમરજન્સીમાં આઉટ ઓફ ક્વેશ્ચન થઈ ગયું, રાઈટ? એટલે કાર્ડિયોજેનિક શોક, હિમોડાયનેમિક ઇન્સ્ટેબિલિટી અને સસ્પેક્ટેડ મિકેનિકલ કોમ્પ્લિકેશન. હવે વિચાર લો એમઆઈ વેર યુ નોટ સસ્પેક્ટ મિકેનિકલ કોમ્પ્લિકેશન. એસટી એલિવેશનમાં કયા છે ભાઈ જેમાં તમે મિકેનિકલ કોમ્પ્લિકેશન એક્સપેક્ટ નહીં કરો?
Any of MI can
Any of them are practically, right? So whether it is mentioned or not, fortunately જો hemodynamic stable રહ્યું patient તમારું throughout procedure, તો તમે procedure પછી echo કરો, fine. Otherwise echo is mandated. ભલે આમાં લખ્યું એક ના લખ્યું.
The question is arrived that based on echo finding we cannot directly jump onto the whether it is.
That is a different story. Here the role remains to see the complications.
Yes.
Right? And sare je Dalal sare last time that question કીધો તો it was very very important. You can save lives. ECG માં troponin માં ના હોય અને તમારો echo બતાવી દે regional wall motion pause, you need to pray God કે તમે પેલું પકડી પાડ્યું.
અમારે
મોકા ઓછા મળે.
ડિસ્કસ કર્યું ને
But it is a rarity. હવે આજકાલ ક્લિનિકલ ટચ રહ્યા નથી કે તમે ECG માં troponin આવે એ પહેલા તમે MI પકડી પાડો તો તમારું તો બંદી પડી જાય. So એના માટે એ જરૂરી છે.
આ કન્ટેન્ટ વાળું શું છે એ કઈ એક્સપ્લેનેશન કન્ટેન્ટ રપ્ચર એટલે એની તમારા કીધું કે આ શું એક્ઝેક્ટલી કન્ટેન્ટ રપ્ચર એટલે
કન્ટેન્ટ રપ્ચર એટલે પેરિકાર્ડિયમને ત્યાં કાઢી દીધું હોય, તમે ઇકો મૂકો ને તો તમને ટ્રાન્સમ્યુલર ગેપ દેખાવા માંડે પણ હજી બહુ બધું બ્લડ બહાર નીકળવાની શરૂઆત ના થઈ હોય એટલે ઇમ્પેન્ડિંગ ટેમ્પોનેટ જેવું થયું કે થોડા ટાઈમ પછી આગળ જઈને થઈ જશે
એટલે ત્યાર પછી નીચેનું ચોથું આવી જાય ફોર્થ
પછી રપ્ચર આખે આખું
Fragile wall.
તમને રપ્ચરમાં દેખાય બ્લડ જાય છે ત્યાં પણ આખું બહાર ન થતું પાછું.
એટલે પેરિકાર્ડિયમ ઇન્ટેક્ટ હશે.
પેરિકાર્ડિયમ ઇન્ટેક્ટ થઈ ગયું કે ગમે તેમ પેલું કહેવાય ને બોર્ડર સિક્યુરિટી ફોર્સ મહેનત કરે છે દુશ્મનોને અંદર આવવા માટે એટલે અટકેલું છે પણ ઇટ માઇટ ગો ઇન્ટુ રપ્ચર કમ્પ્લીટ.
ફ્યુચર ડિરેક્શન પતી ગયું
Direction
એટલે કંઈક તમારે હાઇલાઇટ કરવાનું છે ફ્યુચર ડિરેક્શન
only de-escalation of antiplatelet therapy, yes, sir already said. Anticoagulant for anti-overall infarction, management of post-time pericarditis, as we discussed. Selection of patient for mechanical circulatory support, strategy to reduce vascular complication, timing of placement and duration of support, and rescoring to guide treatment strategy based on the coronary angiography finding. Those patients who survive out of hospital arrest or comatose based on their patient selection for reperfusion therapy. Duration of telemonitoring, monitoring and optimum was class 2, but now it is class 1. At the time of primary PCI, do standing of another vessel also. It will, for those patients who having severe stenosis more than 90%, and for those who have adverse myocardial, it will be like myocardium will be salvaged and prognosis will be better for those patients. What those high risk patients. And SGLT2, hemoglobin, supplement, whatever the iron or blood transfusion. Apart from that, circulatory valves pattern, aldosterone antagonist, beta blocker, ACE inhibitor. Those who are unstable, then circulatory device will be beneficial in class 2 medication. And always CVT is backup for patient does not survive PCI, like major complications.